Our final presentation for today is from Sian from Central Coast Local Health District, and the presentation is on bringing the carer perspective to healthcare planning, the carer readiness tool.
Thank you, Melissa. I want to welcome everybody. I'd also like to bring up my slides, if that's okay, Jonathan, in the background. I don't know whether everyone can see those. Yes, they can now. Next slide, please. I'd like to acknowledge, this is our acknowledgement to country for people visiting our health district. I come from Darkinjung Land and speaking to you from Darkinjung Land today. I'd like to acknowledge the traditional custodians of the land. We acknowledge and recognise the First Nations people who have come from their own country and come to our country. We pay our respect and acknowledge our First Nations ancestors that have walked and cared for these lands for many generations before us. Acknowledge our elders who are our knowledge holders, teachers and leaders, and our youth who are emerging leaders in this community. We recognise the unique cultural and spiritual relationship and celebrate the contributions of First Nations people to Australia. Thank you. Next slide. Well, I've only got 20 minutes to talk about 3 years of work, and a huge thank you to Communities and Justice for funding our research project through the Carer Investment Project. Next transition, please. We talk to carers every day at the Carer Retreat, and I guess that those people have had, those carers that have had experiences with hospital, perhaps over a few years, will recognise that there's a real push for people to go home as quickly as possible, to where it's familiar and safe and quiet. Hospitals are very noisy places, especially if somebody's confused. Next transition, please. But, you know, how ready are the carers? You know, are the tasks that carers doing, are they out of their comfort zone? Are carers confident perhaps with all of the tasks that they are required outside of the practical emotional tasks? So that's where this project was born. It really is about looking, addressing what carers had brought us anecdotally to the Carer Retreat and using the resources and funding from Communities and Justice to walk the walk with carers through the hospital sector and to make a difference. Next slide, please. And really what I want to talk about today are the two things, and next transition. The first thing is around carer identification, and thank you to Deirdre for raising the issue of that. It's really hard. Carer identification is a hard task. Now, we've published on our findings for that, and I will briefly talk about it today. That's the first thing I wanted to talk about. But secondly, I wanted to tell you about the lessons that we learned from carers around their issues with engagement and partnership in health. We have published on the development of the Carer Readiness Tool, and that's the second paper there. So next slide, please. Identifying carers, which is the first thing I want to talk about. Generally, what happens is we ask, are you a carer or do you have a carer? Because in health, we identify that and we record it in electronic medical records. But really, when we took the journey with carers and we talked with patients and carers and staff, we found that we really weren't getting the right answers to the questions. A lot of the staff asking that question actually thought they were asking about support workers and not family members in a caring role. So already the person asking the question were misinformed, understood the term. Carers themselves and a lot of the patients that we spoke to didn't really like the term all that much. It had certain misgivings and misunderstandings around dependence, and that's not what the carer thought they were doing. So when we continued to reflect and talk to carers about their challenges with being labelled, which they didn't want, and the patient didn't necessarily want to be known as someone who is dependent on a carer, because that all caring relationships are quite different. Next transition, please. So in fact, what we were doing, the reason we were asking was not to label people and just to write it in our electronic records. The reason we were asking was because we wanted to know who the patient relied on. Remember, I'm talking patient because I'm talking about the hospital interface. So we really wanted to know from the patient, who do they rely on and who do they want us to involve in their care? Because really we're striving towards that partnership, because let's face it, when people come into hospital, often they're not very well. They're not good health historians, and they do take the journey with somebody else who is their carer, who often knows them better. So the reason that we're asking the question is because we want to know who the patient wants us to partner with. We didn't necessarily want to label. So we needed something different. So we worked on that terminology around rely on and involving care. Next slide, please. Again, we took the journey. We decided, where should we focus our work? So we looked at the touch points in health. Where were carers and patients most likely to interact with the question of, do you have a carer? Is there a caring relationship? So we looked at the touch points and we found that it was likely to be the ED staff, the emergency department staff on that triage, that entry point. It was our administrators and our staff who did patient registrations, who were the ones we needed to work with. We looked at scripts, so we wrote with those staff scripts, and basically we wanted to know who is the person that supports you in practical ways with any medical or health concerns, with your emotional support or other financial supports. So together with carers, we put together this poster which looks at the things that carers do rather than trying to define what the term carer actually meant in our context of health. We work with health service staff on SOPs, which are standard operating procedures, so they knew why they were asking the question and what they needed to do with the information. We developed with the staff a training manual that brought the carer voice to the reason why it's important for carers to be identified in health. And a QRG is a quick reference guide which essentially tells the admission staff how to press the right buttons to get the right information in our electronic system. Now, we didn't just want to know, did this patient have a carer? We did want to know 5 elements. We wanted to know, is this person in a caring relationship for someone else? Is this patient a carer? So we wanted to know that. We wanted to know if the patient had a carer, 2. 3, we wanted to know, in some circumstances, we know that caring relationships aren't black and white. Sometimes a patient can be coming into the hospital. They can be a carer for somebody else, husband with dementia, and they can also be reliant or relying on a daughter to support them through a cancer scare or a cancer treatment. So they can be both. We also have situations where people aren't carers at all, so that was non-applicable. And then the final one, sometimes we don't know. Sometimes people say, well, I don't know, don't want to answer the questions. So we needed an unknown as well. So when we did all of this work, did it make a difference? Next slide, please. So here we can see, and again, very, very quickly, we started in April 2019, and we're looking at the red line there, which is not applicable, not relevant to me, don't have a carer, not both, no, not relevant, which is the red line right up near 90. Down the bottom, around 13% was people who identified with the term, or we asked the question and got the right answer. So we identified the carer, which is the blue. As we started to work at the key touch points with the scripts, with the post, with the QRGs and SOPs, we started to move closer to what we expected the caring relationships to be, which is around about 50%. Let's face it, I mean, the average in the community, we're looking at 10, 11% of the population being a carer, but in hospital, we wouldn't expect that same percentage, surely. There's more caring roles because people are more likely to be unwell or have complications with their health care in and be in a hospital setting. So we did expect to see more carers in hospital. You'll see that little glitch there where we went up and down. There's COVID. So all of a sudden, not applicable went up very quickly, but settled back down once again the admissions staff and the registration staff got more comfortable with all the COVID questions that went on top of all of the questions that they were asked around that time. So we did level it out. So that's around carer identification. And again, if you wanted to know more about what carers told us, what patients told us, and why, the barriers that's in those papers. So the second half, next slide, please, that I wanted to talk about was engaging carers. I mentioned the push for reduced length of stay in hospital, but then highlighted again that the impact of that is often carers become physios. They had to perhaps attend to additional wounds. They may even be giving substances via injection, a whole load of complicated things, stomas and whatnot. Often is the additional burden to carers if people are leaving hospital quicker. So some people are fine with this, but then some carers just weren't. So how were we engaging carers, and how did we find out whether carers were ready for this or not? We took the journey again with carers and patients, but also spent multiple hours sitting in multidisciplinary team meetings to hear what clinicians were saying around caring relationships and about that transition to home. So next slide, please. So what did carers tell us along that way? And we spoke to over 200 carers during this period of developing a process for bringing the carer's voice to healthcare planning and informing clinicians about who they are and what's happening for them. Carers were telling us they felt invisible, but they also felt on call. You know, when it's time for the person to go home, guess what? I get the phone call, you know, mum's ready to go home now. It's like, what? I thought yesterday you told me she was in for a couple more days. Next, please. They felt pressured. Often the questions were asked in front of the patient, and they didn't want to upset. They didn't want to appear not to want the person to come home, but they were feeling their own pressures about, am I ready? Am I confident enough? Next, please. So the carers often talk to us about the one-way questioning, clinicians asking them these sometimes yes and no questions when carers actually wanted to qualify their answers and give more detail. For example, you know, how's so-and-so in going to the toilet? Is that an issue? Well, no, not during the day, but in the middle of the night when they're tired, I'm afraid they're going to fall. So sometimes it was all very one-way communication. Next, please. Duplication and frustration. Carers told us, you know, sometimes it seemed that the physio was asking exactly the same question that the OT did, you know, and don't these guys talk to each other and write down what I say? I told them yesterday. So from a carer's perspective, they often think that a clinician is asking them the same thing. And their frustration is that the carer isn't being asked what's key to them. Next, please. So carers have got the physical stuff. I mean, culturally, sometimes the things that we're asking somebody or expecting a carer to do once they're home is actually not culturally appropriate. Has a carer had the chance to let us know if there's any of those sorts of issues? What about the carer's physical health and well-being? What about any sort of fears, phobias, previous unfortunate experiences? For example, with giving injections to somebody else, I mean, showering somebody, all of these sorts of things. When do we give the carer the chance to have a voice? And the final point here, carers wanted to be heard, but they didn't want to be tested, they didn't want to be assessed, and they didn't really want to be judged. They just wanted their key concerns flagged, and not at the last minute while they were trying to get the person out the door with their medications and talk about, well, what do I do when I'm home and X happens? So they didn't want last minute. Next, please. So what did clinicians tell us when we took the walk and the talk and we listened to clinicians? They often said, well, that they don't have the capacity to assess carers. They are patient-focused and that's their priority. However, when we're speaking to carers didn't want a full assessment. They just wanted to flag their concerns. Next, please. Often the clinicians said, well, we did consult with the carers, but we didn't see a lot of evidence of that in notes, and we didn't see a lot of evidence of the dialogue between one clinician being reported in context, but also in detail in the patient records. Next, please. Clinicians saying they're time poor and don't have time to meet patients' needs, as well as doing full assessments and meeting carers' needs. They were misunderstanding what carers want. Carers wanted to flag, not an assessment. And the final point there, they needed something that was accessible. Bringing in additional written information, stories, or whatever else wouldn't work for them. Next slide, please. So the Carer Readiness Tool was born, and I need to acknowledge that, yes, we did trawl the literature looking for something that was fit for purpose that we actually couldn't find. However, what we did find from Next Step in Care, the United Hospitals Fund in New York, was some nice online tools that we shared with our carer consultants. We had a team of carer consultants that we would consult with, plus we shared those with those carers that were already in the inpatient setting to see how doable this was. It was about me. It had to be about me, not about the patient. It was about who the carer was, tasks of caring, their concerns and worries. Carers didn't want a test, and carers wanted something paper-based so they could reflect. They didn't want the questions here and now in the 5 seconds that a clinician had to ask. They needed more time to sit and reflect. They wanted some structure. The next part for clinicians, next please, it needed to be relevant to patient care planning. It needed to flag concerns, not be an assessment, and it needed to be readily accessible in our electronic records. Next slide, please. And very, very quickly, this is what we developed. Over time, we've developed this as an online tool. It is available in electronic medical records, and this is actually a self-fillable PDF, so it can be emailed to carers. In COVID, paper and carer visits, it wasn't going to work. So this is a fillable form that carers can fill in at home and then email back to us. It goes into electronic medical record, and for all clinicians to see all of the information all in one place, not scattered throughout the notes. It gives clear structure, and what carers have said is that, yes, it gave them an idea of what all of the clinicians wanted to know, not just this one and then this one and then this one, and they repeat and duplicate. Carers had a chance to reflect, consider, tick off what was key important things for them, and all clinicians have access to that information in one place in the electronic record. So now it is electronic based. Last slide, please. So I've talked today about carer identification strategies, and we have published on that. The Carer Readiness Tool, again, we've published on the co-design process of developing that tool and how vital carers were to what the final product ended up being. And again, thank you to our consultants that helped us go through the multiple drafts. I'd like to acknowledge Communities and Justice for the carer investment funding, because without that, we wouldn't have had the time for true co-design with carers. Final slide. I'd like to say thank you, and I look forward to hearing from anyone with questions. I know there must be loads of questions. We know it's a feasible tool. Carers like it. Clinicians like it. It is a way for bringing the carer voice to care planning, and it will help with transitions to home. So thank you, Melissa. Thank you, everyone, for listening.